My name is Shinsuke Miyazaki from Tokyo. I'm very honored for the invitation. So today I'll talk about the complications of pulse field ablation. So these are my disclosures. So the pulse field ablation is a novel energy source. So unlike the conventional catheter ablation energies, which use radio frequency or cryothermal energy, PFA utilizes pulse electric fields to induce reversible electroporation, leading to targeted tissue destruction. In Europe, recent approval resulted in rapid real-world adoption. So in Japan, three regional catheters, Vipulse and Pulse Select and Parapulse, were approved last year, and the Afera system will be approved next year. So this slide shows the ablation device share in AFib ablation in Japan. Unfortunately, I do not have the nationwide data, but I looked at the large ablation registry of 20 Japanese centers. So green indicate radio frequency catheter ablation, and orange indicate cryoballoon ablation, and blue indicate PFA. As you can see, that after the PFA introduction in the September 2024, the share of the PFA dramatically increased during the short period. And currently, the pulse select system and the Parapulse system are similarly used in Japan, and a small portion of the people use Vipulse system. So PFA induces selective cell death without thermal damage, and the treatment can be performed while preserving the structural integrity of surrounding tissues. And because of minimal injuries to surrounding non-cardiomyocyte tissue, so this targeted approach offers distinct safety advantages. So the efficacy and the safety of the pulse field ablation depends on the created pulse electric field, and the pulse electric field is determined by the pulse parameters and also catheter configuration. As you can see, there are various pulse parameters which make up the delivered pulse electric field, and they are unique and proprietary to each commercial PFS system. The catheter configuration is also very important. For example, in the Parapulse system, there are two catheters with a different maximal diameter, and during the procedure, we need to change the catheter configuration, flower and basket configuration. Even if the PFA parameters were similar, of course, the created pulse electric field should differ between the flower and the basket configuration. We should also recognize the incidental heating from PFA. So generally, pulse delay is required for not only recharge, but also cooling. As you can see, if we increase the pulse duration or field strength, the thermal energy is created. So we need to recognize the current PFA system is not pure non-thermal system. So this is very interesting analysis using computer modeling. A 3D computer model of the LA and the esophagus was created to quantify the thermal effects from PFA applications. So they demonstrated that thermal effects induced by PFA depend on total energy deposited, of which peak voltage is an important component, like this, and suggesting that current commercially available systems appear to have the potential to induce collateral thermal injury, particularly with repeated applications of pulse field energy. So this is confirmed in clinical study. So this single-center prospective study investigated the esophageal temperature during ablation lesion delivery in proximity to the esophagus. As you can see, the esophageal temperature transiently rise with the Afera system and Parapulse system, but not with pulse select system. So variable esophageal temperature rises can occur on different ablation platforms. So let me check the complications of pulse field ablation in the Manifest 17 case study. As you can see, the most common complication was vascular complications, followed by the pericardial effusion and phrenic nerve paralysis and stroke. But the rate of these complications decreased over time. So I pick up several complications of PFA. So in the ADVENT trial, which compared the pulse with the thermal energies, the incidence of the symptomatic stroke was 0.3% in both groups. And in the sub-analysis of ADVENT trial, the rate of silent stroke was also similar between two groups. However, if we look at the core laboratory review, all three silent stroke patients were included in the PFA group. So on this background, we directly compared the silent stroke risk between the different PFA systems under identical conditions, Varipulse system and pulse select system. So all patients underwent PVI and LA posterior wall isolation. As you can imagine, the number of PFA application was greater in pulse select group, whereas the rate of silent stroke was significantly higher in Varipulse group. So this slide shows the MRI image in Varipulse group. As you can see, the 6 patients had multiple silent stroke lesions, and half of the patients had a large silent stroke lesion. So differences in the PFA parameters and the electrode configurations likely contributed to the two systems' differences. And in addition, in the EMBL AFib registry, which is reported on the ERA meeting this year, the incidence of the symptomatic stroke was higher in the PFA group than the thermal energy group. So I think that the stroke is an important complication of pulse field ablation. Hemolysis is also important complication of pulse field ablation. Electric field intensity exceeding a certain threshold leads to the disruption of erythrocyte membranes, causing cell rupture and the release of free hemoglobin. Several previous reports showed hemolysis after pulse field ablation, regardless of the systems. And cell-free hemoglobin is an important driver of adverse disease process, leading to the acute kidney injury, vasospasm, and thrombosis. So we evaluated the hemolysis level in each different system. So the study included patients who underwent PFA, pulse select, and parapulse, and those who underwent cryoballoon ablation as a control. So this is the level of the free hemoglobin before and just after PFA. So as you can see, the parapulse had significantly higher level of hemolysis biomarkers and free hemoglobin than pulse select. Similarly, a greater number of patients with low-level haptoglobin was observed with parapulse than pulse select. So major contributors to hemolysis are electric field strength and the number of PFA applications, baseline renal function, and suboptimal catheter tissue contact, and inadequate postoperative fluid supplementation. So we needed to limit the number of PFA applications, especially using a parapulse system. However, if you look at the literature, even with 50 PFA applications in the parapulse system, AKI could occur. So we need to take care of this complication. Coronary spasm is also a very important complication. If the energy is delivered adjacent to a coronary artery, PFA provokes vasospasm. So CTI ablation may provoke the vasospasm of right coronary artery, and the lateral mitral isthmus ablation could provoke the vasospasm of left circumflex artery. So if the spasm is severe, significant ST segment elevation is observed and leading to AV block and ventricular fibrillation. And it is important to say that so this could occur even after PVI only. So the risk is not limited to single-shot catheters with a wide footprint, but also a focal point catheter. Air embolism is also one of the important complications. Inadvertent air embolism during catheter introduction into the sheath is the main mechanism producing coronary air embolism. An abstract presented in Heart Rhythm this year showed the rate of air intrusion into pulse-field ablation sheath. So as you can see, the rate is higher when using the Farah-derived sheath than that in the with the FlexCat sheath or the Vigigo sheath. And I strongly recommend to use the water bucket when introducing the catheter into the large bore sheath to prevent this complication. So gastroparesis is an also important potential complication of PFA. So this NICE study included 228 patients who underwent PFA with a parapulse catheter, and all patients underwent upper endoscopy within 1 day after the procedure. So the endoscopy revealed the no esophageal lesions, but silent gastroparesis was observed in 4% of the patients, and those patients underwent PVI only. So damage to periesophageal nerve is thought to be involved in periesophageal nerve damage. We should also know the impact of PFA on the esophagus. So this is also a very nice animal study. After PFA, animals were sacrificed either 1 day or 14 days after the procedure. After 1 day, most of the animals demonstrated esophageal lesions, and all lesions were non-transmural. And the 14-day cohort exhibited no lesions on gross microscopy or histology. I think maybe we should avoid repeated application on the posterior wall. Finally, I pick up the phrenic nerve injury. This study included 64 patients. They evaluated the incidence and the characteristics of phrenic nerve injury during PFA using CMAP monitoring and assessed diaphragmatic function at discharge. They elegantly showed that phrenic nerve injury was observed during the procedure in 40% of the patients, and it remained at discharge in 24% of the patients. So phrenic nerve injury appears to be a frequent event during PFA for AFib and often persists in an incomplete form at the end of the procedure. So in conclusion, ladies and gentlemen, although PFA is generally considered a safe energy source, it is important to be aware of its unique procedure-specific complications. Thank you for your attention.